Welcome to this new Gentian webinar in our Calprotectin webinar series. My name is Paula Lindner and I'm the product manager for GCAL, the Gentian Calprotectin immunoassay. Today I want to give you a short introduction into the biomarker Calprotectin and highlight some of the clinical application areas. This is the outline for this webinar, where I will give a short introduction into the protein Calprotectin itself, followed by a short excursus to the use in infections, COVID-19 and rheumatoid arthritis, finishing with the Calprotectin assay available from Gentian. I want to start to give a small introduction and background information about the protein Calprotectin. Calprotectin belongs to the S100 family of proteins, a superfamily of calcium-binding proteins, which are essential components of the immune response. Calprotectin is the heterodimeric complex of two S100 proteins, S100A8 and A9. Synonyms for the heterodimer calprotectin you will also hear regularly are S100A8A9 and myeloid-related protein MRP814. Calprotectin is mainly expressed by phagocytes like neutrophils, monocytes, and macrophages, and makes up a large proportion of the cytosolic protein in these cells. Calprotectin is a key alarmin released in the first-line immune defense as response to infections and non-infectious inflammation. Its antimicrobial activity is mediated by the sequestration of zinc and manganese from the bacterial environment, and thereby starving the pathogens. Calprotectin is also a pro-inflammatory transmitter, mainly by binding to two receptors, RAGE and the toll-like receptor 4, driving the procession of inflammation. And due to its fast and direct upregulation in the inflammation reaction, Calprotectin has been shown to be a valuable biomarker in a whole range of inflammatory conditions, including bacterial infections, lately also in severe COVID-19, but also in non-infectious inflammatory conditions, including autoimmune diseases and rheumatoid arthritis. One important aspect of Calprotectin as biomarker is its kinetic. Since Calprotectin is readily available in neutrophils, it will also be released very fast upon infection or inflammation. In this experiment, healthy volunteers received endotoxin mimicking a bacterial infection, and the kinetic of Calprotectin in their blood was measured. As you can see in these three graphs, the Calprotectin release was already measurable after 2 hours and peaked at 4 hours, while it was normalized within 24 hours. And PCT and CRP showed slower kinetics. PCT had a peak of around 8 hours and normalized after 48 hours, while CRP had the slowest kinetic, reaching its peak only after 24 hours. This kinetic is important to remember, especially in the clinical settings where very early detection of inflammation can be crucial to provide fast and timely treatment. So now let's take a bit more detailed look into the use of Calprotectin as biomarker in bacterial infections. As I've already mentioned, Calprotectin will increase during the inflammatory response in bacterial infections, and therefore high Calprotectin levels will be found in infected patients versus healthy individuals, but also compared to patients with viral infections, which does normally not cause an inflammatory response. So Calprotectin can be used as a discriminatory biomarker of bacterial versus viral infections. These results obtained with the Gentian GCAL assay defined a cutoff of 2.37 mg per liter for the distinction of bacterial versus viral infection, with a 60% sensitivity and a 79% specificity. Interestingly, Calprotectin is also increased in mycoplasma infections, allowing discrimination of mycoplasma versus viral infection, which is not seen with other inflammatory biomarkers and can be very helpful for this hard-to-diagnose condition. Another important diagnostic is discrimination concerns infections versus viral inflammation to guide the appropriate treatment decision. Calprotectin is indeed able to differentiate between sepsis patients and patients with viral inflammation and trauma, while the levels of PCT are elevated in both patient groups and can therefore not be used to distinguish the patient groups. One important outcome of biomarkers is, of course, the improvement of treatment. In this regard, calprotectin is able to predict the need of antibiotic prescription one day before the clinicians will start the treatment. Based on these results, calprotectin can help to decide on early treatment start and thereby also improve the subsequent outcome and possibly prevent more severe events for the patients. Finally, I want to highlight the risk stratification of calprotectin in bacterial infections. Calprotectin levels do increase with increased disease severity, and calprotectin is a good predictor for severe outcomes like mortality. In this second part, I want to highlight the recent advances of calprotectin in COVID-19 diagnostics. First of all, it's important to understand why calprotectin is even considered a potential biomarker in this viral infection. As we all know, SARS-CoV-2 infections can lead to COVID-19, and severe cases have fatal consequences, and therefore risk stratification is an important tool in COVID-19 care. Interestingly, in COVID-19 patients, the hyperinflammation response and neutrophils are activated, and SARS-CoV-2 can even lead to viral sepsis, which involves some of the same pathways as bacterial sepsis, the pro-inflammatory receptors Toll-like-4 and RAGE, which, as I mentioned in the beginning, are also target of calprotectin. Therefore, calprotectin can, in this unusual viral infection, also serve as a neutrophil activation and early inflammation marker, similar to its diagnostic value in bacterial infections. So now let me just quickly illustrate some of the examples describing the value of calprotectin in COVID-19. First of all, calprotectin levels increase with disease severity from healthy patients, COVID-19 patients, and patients in need of ICU admission, as well as from survivors to non-survivors. So calprotectin is a strong predictor of ICU admission and mortality, thereby enabling a target care for patients at risk. So calprotectin has predictive capacity, identifying patients at risk higher the tier in regards to ICU admission and multi-organ failure. Finally, calprotectin levels are also closely connected to the need of mechanical ventilation, showing increasing calprotectin levels in patients in need of mechanical ventilation. These results obtained with the Gentian GCAL assay defined a cutoff of 2.98 mg per liter for the prediction of need for mechanical ventilation and 3.09 mg per liter for the need of ICU admission. Now I would like to present some background related to the use of calprotectin as inflammation marker in rheumatoid arthritis as an example of the clinical value of calprotectin in inflammatory conditions. In RA patients, calprotectin is released in the inflammation in the joints and is therefore an interesting candidate to assess the inflammation activity. Going directly to the site of inflammation, calprotectin concentrations are high in the synovial fluid obtained from the joints of rheumatoid arthritis patients. And since its low molecular weight allows calprotectin to enter the systemic circulation, it can be measured in the blood, where it directly reflects the inflammation in the synovial. Importantly, calprotectin correlates with disease activity as well as a decrease of inflammation under effective treatment, and calprotectin correlates with the rheumatoid factor and many RA clinical scores. And in addition, calprotectin correlates also with other inflammation markers typically used in RA diagnostics like erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP. However, calprotectin can be a superior inflammation marker compared to ESR and CRP because calprotectin can detect low-grade inflammation and subclinical activity where classical inflammation markers are not increased. So again, let me just quickly show you some examples of the clinical use of calprotectin in RA. Calprotectin levels are significantly lower in patients in clinical remission compared with those with low disease activity, and also show a stepwise increase with disease severity. In addition, calprotectin levels correlate better with activity indices than CRP and ESR, and only calprotectin is able to distinguish between remission and low disease activity. This last important point, that calprotectin can even distinguish between patients in remission and patients with subclinical low-grade inflammation activity, is crucial since in some patients in clinical remission, low-grade inflammatory activity may persist but remain undetectable by routine clinical examinations and laboratory tests and might only be visualized by ultrasound. Calprotectin has the capacity to distinguish between patients in ultrasound-defined remission and those with residual ultrasound subclinical inflammation, while CRP is not able to distinguish between these patient groups. Another important feature of calprotectin is that it can be used to assess disease activity also under treatment inhibiting inflammatory proteins. Calprotectin correlates with disease activity also in RA patients receiving IL-6 inhibitor treatment, while CRP levels are influenced by the treatment itself and do not reflect the true inflammation status of the patient. With that, we are almost at the end of this short overview of clinical application areas of calprotectin as biomarker, which was still just a selected representation of multiple areas of use both in infections and several inflammatory conditions. In summary, I hope you've taken from this presentation that calprotectin is an early biomarker in response to infections, which can be especially useful when monitoring vulnerable patients at the hospital, enabling a fast response by the clinician and a possible earlier treatment intervention. Calprotectin can differentiate between bacterial and viral infection as well as sterile inflammation like trauma, which is crucial for the appropriate treatment decision. Calprotectin can also indicate the level of severity both in bacterial infections and COVID-19 patients, helping clinicians to identify patients in need of extra care and follow-up. Calprotectin is also a prognostic marker and can predict severe events and mortality, aiming to help prevent the development of sepsis and severe events in bacterial infections and COVID-19 by aiding in targeted patient care and treatment. Calprotectin also has a high clinical value in non-infectious diseases like RA, where it correlates with disease activity and severity and can be helpful to monitor patients under treatment and in remission for the treatment response and relapse, also when other inflammatory biomarkers are not sensitive enough. Lastly, I want to highlight that calprotectin can also be used in liver patients and neonates, since its production is dependent of neutrophils and these are part of the innate immunity. In addition, calprotectin can be important when monitoring patients receiving IL-6 inhibitor treatment, where other inflammation markers like CRP are not applicable. Finally, I want to highlight the turbidimetric calprotectin assay available from Gentian. Gentian's calprotectin immunoassay called GCAL is a turbidimetric assay specialized for calprotectin testing in serum and plasma samples with dedicated reference ranges and specifications. It is rapidly performed in only 10 minutes with ready-to-use reagents, and since it's an open channel assay, it can be applied to a wide range of clinical analyzers and thereby be integrated in installed instrument base at your laboratory. It is CE marked, so it's available for diagnostic use in serum and plasma to provide fast information about the patient's inflammatory status to the clinicians. Thank you very much for your attention, and please reach out to us if you have any questions or would like to receive a validation kit.